Hello, everyone. Thank you for joining us for today's session. We've been looking forward to this one for a long time on behalf of Pallium and our wonderful presenters who have joined us today. I want to welcome you to today's ECHO session titled Interprofessional Rehabilitation, Engaging in a Palliative Approach. So we're going to have a chance for our presenters to introduce themselves in depth in a couple of slides, but in the meantime, feel free as audience members to introduce yourselves in the chat. So before we get things started, I would like to begin by acknowledging that the city of Toronto, where I am based, sits on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, Haudenosaunee, and the Wendat peoples. It is now home to a rich and diverse community of First Nations, Inuit, and Métis people. And I also recognize that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, as well as the Williams Treaty, signed with several Mississaugas and Chippewa bands. As we come together remotely for today's session, we recognize that people are joining us from across the country, which belongs to many traditional nations. We acknowledge these treated and unceded lands and the responsibility we share to honor and respect their histories, cultures, and contributions. We'll go to the next slide. Okay. For anyone who's new to the Palliative Care ECHO project, that is the name of this initiative that was funded by Health Canada, and our goal with this initiative is basically to cultivate communities of practice and ongoing professional development opportunities for healthcare providers and individuals who care for patients with life-limiting illness and their close ones. If you haven't had a chance, please check out the website at www.echopalliative.com. Also, just to mention, one of the principal or cornerstone programs that Pallium offers that may be of interest to individuals attending today, if you haven't already taken it, is LEAP Core. This is an interprofessional course that focuses on the essential competencies to provide a palliative care approach. This is fully accredited, both with the CFPC, the Royal College. It's developed and taught by palliative care and education experts from across Canada. So check it out at pallium.ca/courses, and you'll see different types. Now with introductions, I'll just introduce myself and then turn it to each of our presenters for them to introduce themselves. I'm Holly Finn, and I'm the Senior Manager of Program Delivery here at Pallium Canada, and I'll be your host for today. I'll turn it to Julie.
Hi everyone, I'm Julie Wilding. I'm an occupational therapist. I'm currently doing a PhD at Lancaster University in the UK, but based in Oakville in Canada in Halton Healthcare.
And I'm Jennifer Forward. I'm an occupational therapist currently working with the primary healthcare team with Newfoundland and Labrador Health Services.
Hi everyone, my name is Naomi Dolgoy. I'm an assistant professor at occupational therapy at the University of Alberta and a practicing occupational therapist with Alberta Health Services.
Hi everyone, my name is Bonnie Cook. I'm an audiologist and I'm the Director of Audiology at Speech Language and Audiology Canada.
Hi everyone, my name is Lisa Carroll. I'm the Senior Director of Professional Practice at the Canadian Physiotherapy Association, and I also have a past career as a physiotherapist assistant in Ontario working in long-term care facilities.
Hello everyone, I'm Jennifer Cameron Turley. I am a speech language pathologist and I am currently working as the Interim Director of SLP and Communication Health Assistance at Speech Language and Audiology Canada.
Great, thank you. I can now advance my slides because before the comments were popping up and I couldn't press the button, but I am going to now get us to the next one. So just in terms of some housekeeping, remember for comments, any introductions, you're welcome to use the chat function. For any questions, we kindly ask that you use the Q&A box or function, and this is a way for us to gather all those questions together, and they'll be addressed at the end of today's webinar. Please note that this session is being recorded. Both the recording and the slide deck will be emailed to registrants within the next week. And also as a reminder, please, if you are asking any questions or putting things in the comments, please do not disclose any personal health information during this session. Okay, Now, in terms of conflicts of interest, Pallium Canada is a nonprofit partially funded by Health Canada that generates additional funds to support its operations, research, and development through course registration fees and sales of the Pallium Pocketbook. Our presenters have confirmed that they have no conflicts of interest to disclose today. Okay, now this is our last slide before we dig into the meat of this presentation. I just want to explore today's learning objectives. Today, we're going to be looking at the palliative care approach, its importance across many different care settings, and the key roles that various healthcare providers, including occupational therapists, physiotherapists, speech language pathologists, and audiologists. And this is not an exhaustive list. It includes a whole host of many other people, but just in light of who the presenters are today, we're going to have a specific focus on that. We're going to talk about how they play a role in supporting individuals with life-limiting illness. By the end of this session, we hope that you'll gain insights into case studies, interdisciplinary care, and the significance of accessible communication in palliative care. And with that, I am going to turn this over to our first presenter.
Okay, so I'm going to get us started. I just want to speak in general, like in terms of what is a palliative approach to care. So these are some key words that are used to describe what it is, and each description refers to an element that supports living life as opposed to focusing on death. Essentially, this makes this approach relevant to all healthcare providers. So in every area of healthcare, there are encounters that have some connection to death, loss, grief, and they are part of life because death is a social concern and it's not a medical condition. So most healthcare providers will work with those that are experiencing experiencing chronic conditions. So that is not end of life. And they're already positioned to provide for their palliative needs from the beginning of the illness trajectory, which we'll illustrate today. So each healthcare provider, therefore, needs to be prepared to weave in a palliative approach to care in moments of need alongside of the clinical tasks that they're being trained to do. The palliative approach to care is everyone's responsibility. So despite it being challenging work, all healthcare providers are called to integrate this caring approach into their practice as palliative care generalists, as well as caring for themselves. Practicing a palliative approach to care is simply good person-centered caring. So you will all have received the case study from Diana about Joe. So each of the disciplines today is going to focus their attention on this case. But each of us are going to bring a unique set of skills to the case. But collectively, we all engage in a palliative approach to care while delivering care to Joe from the time he is diagnosed. We're integrating a palliative approach to care into practice requires an ongoing openness to engage and connect with Joe, to establish his person-centered needs and develop his changing goals at any stage of the illness trajectory. The approach is focused on Joe as a whole person to include his social, emotional, and spiritual needs alongside of physical needs in each person-focused caring interaction. So in short, using a palliative approach to care for Joe means that the team needs to consider Joe's story and values as a young father with 2 young children, the importance of continuing in that role, as well as a husband and a CFO of a large multinational organization, and maintaining a positive relationship to his work role. In short, to attune to Joe's perspective of not being afraid to look ahead and adapt his home and to make provisions for his family for the future. We're also interested in exploring how Joe is processing his advanced head and neck cancer diagnosis and what does that mean for him, and leaning into the vulnerability of Joe's story to provide opportunities for Joe to be seen, heard, and valued.
So occupational therapists are focused on helping people do the things that they need to do and want to do with the people and in the places that are important to them. That is, participate in their valued life activities. OTs work collaboratively with individuals and their support system to live lives that are consistent with their needs, their values, and their aspirations. In other words, a person-centered, collaborative, and holistic approach to care. People strive to carry out occupations within meaningful relationships and contexts, what we now call occupational participation. OTs are involved in reframing and tailoring interventions to adapt to the changing goals and roles of their client. As we've discussed, a palliative approach to care aims to support the quality of life of people and their loved ones of all ages who are living with a life-changing illness. The palliative approach to care aims to support people to live as comfortably and fully as possible through the assessment and treatment of functional, social, psychosocial, and spiritual concerns, including through ongoing participation in meaningful activities. Both OT and palliative care share values and core attention to the physical, cognitive, psychosocial, emotional, and spiritual needs through holistic, person-centered practice. The shared values make OT a natural fit with palliative approach to care. Enabling occupation empowers individuals with life-changing illnesses. As we've mentioned, Joe is a young working husband and father who values occupational participation in both his paid employment and his home life. The OT's role is to complete a comprehensive assessment, working with Joe to identify occupations in which he's unable to participate, and working with Joe, his family, his work, and his environment to assist him to continue to participate in his valued occupations. As you've seen from the case, he's having difficulty with stairs and grasping items. OT can work with Joe around edema management through mobilization, positioning, pressure management, and skincare, or compensatory ideas such as a stair lift to get upstairs to put his children to bed, and different computer equipment to more easily access work. OT can help Joe with his memory and fatigue issues by teaching energy allocation and work simplification techniques, reviewing sleep hygiene, and introducing memory techniques such as schedules, to-do lists, and alerts on his phone. OT can work with Joe and his family around his mood and overwhelming feelings of sadness by integrating functional mindfulness, addressing his underlying cause of stress. Next slide. To further demonstrate how our profession of occupational therapy would go about meeting Joe's needs, I would like to introduce you to the Canadian Association of Occupational Therapists practice document. A group of interested OTs have formed a practice group with our national body and were recently asked to develop a practice document on the role of occupational therapy and palliative care. This document can be found at the CAOT website. The document highlights, as we have said, the natural fit of OT and palliative approach to care, but it also highlights the importance of OT working collaboratively with all disciplines. An example of that is here today, and as in the case of Joe. The document also highlights the scope of OT practice across the lifespan and continuum of care. I'm an OT in rural practice, and Joe resides in a rural area. OTs in rural areas can develop a relationship with clients and families as you may be seeing them in multiple settings. Or the OT group is small enough to foster good communication skills between the areas of care. A strategy our area has implemented to encourage ongoing communication for palliative care clients is what is known as whole community palliative rounds, modeled after the Interior Health Program. I'm the facilitator, and weekly, multiple disciplines from 3 areas of care all meet to discuss palliative clients and brainstorm any issues that may arise. We have managers, OT, physiotherapy, speech pathology, pharmacy, paramedicine, spiritual care, nurses and nurse practitioners, and a doctor, and all from acute care, long-term care, and community. An unexpected benefit has been the moral support and encouragement that comes from a diverse group of providers. As you can imagine, working with clients like Joe can be challenging on an emotional level, and this support has been important to the providers to know they are not alone.
So, caring relationships are foundational for meaningful occupation when caring for the dying. There is no meaning without relational action. It's just task-focused automaticity. So being open to leaning into the experience, however challenging, is key to establishing a caring relationship with another. Connections are made in considering a person's story, identifying their values, establishing their needs and wants, seeing them as whole, as we've discussed, physical, mental, emotional, and a spiritual being. So caring relationships build trust. It's empowering for individuals to engage in what is meaningful for them. And connecting in a relational way is not measured in time. It happens in moments with no prior relationship. This palliative caring approach seamlessly integrates into the care that occupational therapists and other healthcare providers are already doing.
You are muted, Naomi. Just wanna.
So few occupational therapists actually work in palliative care, but all occupational therapists and healthcare providers can apply a palliative approach to care in practice. And though research supports using a shared or collaborative model for inter and multidisciplinary interventions, so a palliative care approach to care inherently incorporates this collaboration because there are all these healthcare disciplines working together. So within these shared roles, the individual is central to how and why we are doing this work together. So using a palliative approach to care means that we think about a person in their totality, and we are not labeling or reducing them to becoming their disease or their medical status. So as you can see in this slide, the individual is considered within a whole person perspective. And within collaborative work, clearly defined teams and roles ensures that we carry out effective and efficient multidisciplinary interventions, making the best use of time and resources. So importantly, multidisciplinary teams offer the opportunity to share challenging work, as Jennifer mentioned, and can be used to debrief and support one another because this work can be very heavy. Earlier access to services has been found to be more effective than including rehabilitation disciplines later in care. For example, if Joe wanted a hospital bed for his home, having an ongoing relationship with his occupational therapist is found to be more effective than a one-time consult with occupational therapy only when equipment is required at advanced stages of his disease. For occupational therapy, the importance of function as part of collaborative practice refers to activity function rather than simply biologic function. Because patient status can change so quickly, consideration of functional status requires teams to work together and to be adaptable to support functional capabilities where the patient is at or the individual is at now. And finally, goals and meaning are incredibly significant factors for collaboration within the palliative approach to care. So, what does the person want to accomplish with their time? What is meaningful to them? So, goals, as I mentioned, can be essential, but they can also be measurable. In occupational therapy, we have the Canadian Occupational Performance Measure, or COPM, which can be used in advanced disease populations. It is a measure that addresses patient-reported outcomes over time and can be used to add numeric value to measure goals and changes. Goals can include individually derived goals and also medically focused goals, and these can align or sometimes misalign. For example, if Joe wanted to be coherent and present with his family in his final days, but also wanted pain mitigation, which makes him very drowsy, there needs to be a balance for how to match goals and interventions. Oftentimes, towards the end of life, goals are relationship-based, such as Joe wanting to spend his time with people that matter to him.
The outcomes of using a palliative approach to care generate reciprocal benefits to everyone involved, and these are measured by intuitively knowing that you've connected to meaning. The experience touches a place inside of those involved in the experience, offering fulfillment that sustains and fuels this memorable work and makes a difference to the experience of both living and dying. Death is not separate from life in a palliative approach to care. Healthcare professionals, workers, clinicians can connect tragedy and wonder into life as death unfolds. So Julie, the occupational therapist, remembers caring for Joe, who, despite him being so close to death, regained momentary consciousness in complete defiance of the odds. Julie had seen people return before, straddling the edge of life, as if to resolve the last loose ends. Joe was somewhere in his body, unable to move, hanging on to the last threads of life. Joe's young family came into the room. Julie lowered the bed rails, encouraging the family to come closer. As they gathered around to say their goodbyes, his eldest son remarked, "I don't want Daddy to be a star." This beautiful rendition of our fate after death was told to the boy following his grandfather's demise. "You know," Julie told him, "every single person is made up of stardust. You, me, your mummy, your brother, everyone. We all come from stars." Joe's youngest child sat beside Joe on the bed. Both expressed their delight at the sight of each other, capturing the beauty of the moment. Julie, knowing Joe could not move it himself, placed his hand on the young child's leg, a shared point of connection between one beginning life and the other at the close, each blessing the other on their journeys ahead in what would be their last encounter. Each experience of caring for the dying is different. It is challenging and humbling work, and healthcare providers need to care for themselves and each other in the process, to pause, reflect, and debrief, bear witness together in community. Each encounter, when approached with an open mindset, offers an opportunity for experiential learning to foster growth of the clinician and allowing healthcare providers to continue to care well for others as well as themselves.
Julie, I'm so grateful that I'm here with my colleagues in rehabilitation and bridging over from the incredible work that OTs perform and to speak to you today about how physiotherapy works to find the balance in providing palliative care. So what is physiotherapy and palliative care? How does this show up? It's about finding the balance. Physiotherapy and palliative care centers primarily on providing the maximum potential amount of comfort that is possible for a patient or an individual while maintaining the highest level of physical function, regardless of the disease state or stage that they find themselves progressing through. Physiotherapy professionals play an essential role in supporting individuals with life-limiting illnesses and provide that care and support for their caregivers by focusing on improving that quality of life, symptom management, and enhancing mobility. The World Health Organization defines palliative care as an approach that improves the quality of life of patients, including adults and children, and their families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. Palliative care is not limited to hospice care, but is delivered in many settings, often where you'll find rehabilitation professionals like physiotherapy professionals, including inpatient settings, outpatient clinics, and in the home. Physiotherapists and other physiotherapy professionals like physiotherapist assistants and physiotherapy technologists, which are found in Quebec, play an essential and important role in meeting the needs of individuals receiving palliative care in all settings, and are acknowledged as a vital part of the palliative care team. Research has demonstrated that physiotherapy care can be effective in addressing many of the symptoms associated with palliative conditions, including, when we think of our case study, cancer-related fatigue, pain, lack of appetite and depression, breathlessness, and associated distress. Research has also found that those patients who have participated in an individualized exercise programming and care report benefits, including improved physical functioning, positive psychosocial effects, improved quality of life, and of particular importance, increased feelings of control, independence, and hope. Today, I'll share some of the ways in further detail that physiotherapy professionals can provide care and support as part of that palliative care team. So as I move through these items, we keep our case study in mind and we think of what Joe is going through with his family and with his healthcare team. Pain relief is one area that physiotherapy professionals specialize in addressing, and interventions such as manual therapy and gentle range of motion exercises, whether passive or active, can help alleviate pain and discomfort in palliative care populations. Physiotherapy professionals are uniquely positioned to understand all of the musculoskeletal, neurological, and respiratory cardiovascular conditions and changes as they relate to function, pain, mobility, as that patient moves through the dying process. Often a person, for example, and this is a quote from a physiotherapist providing care in Ontario in a palliative setting, often a person will have lung cancer and be dying of lung cancer, but in fact, it's their low back pain that's preventing them. And maybe it's a metastasis or something of that kind, but it's their low back pain that's preventing them from mobilizing and living the life comfortably that they would like to live. And again, that's something that a physiotherapist and the team can address quite well and manage. When we also think about impacts to the ability to breathe, breathing exercises prescribed by physiotherapy professional can also assist in managing dyspnea, a common symptom in conditions like lung cancer, advanced cancer, and chronic obstructive pulmonary disease. So those breathing exercises can include things like diaphragmatic breathing support and enhance the oxygen efficiency that an individual is experiencing. Another area where physiotherapy professionals can support would be tailoring an exercise program through that progression and through that disease state. So tailored exercise regimens can help with things like maintaining or improving strength, which may not come intuitively associated with end of life or advancing illness, but improving strength can still be tied to an individual's goal and their ability to maintain independence throughout their disease progression. Areas that can also be addressed include balance and coordination that would enable a patient to maintain their independence and perform daily activities more independently, which may be very tied to an individual's self-concept and their goals. Physiotherapists can also assess the need for and train patients and their caregivers in the use of assisted devices like walkers, rollators, wheelchairs, or other devices that can assist with mobility and transfers, and also to prevent falls. Further, when we think about our case study, exercise programs can be prescribed to address edema or swelling in extremities, such as ankle pumps or light exercise, conditions that can accompany terminal illness, and be prescribed to address challenges with mobility and balance so that moving around independently can be maintained. Further, maintaining the ability to lift or grasp objects or manipulate devices. We think of a keyboard, a tablet, or a smartphone that would be tied to Joe's work life or his desire to communicate with family members or friends, can be retained for a longer amount of time throughout disease progression. And these can have a considerable impact on the quality of life and a person's self-confidence. Fatigue management is a huge part of where physiotherapy professionals can come in and play an important role, not only for the individual, but also for their caregiver. Energy conservation techniques can include things like pacing, taking breaks, modifying activities to put the energy where it matters most to the individual, and ensuring that rest throughout the day to align to when energy levels are highest can be incredibly important. Posture management and body control or support in reorganizing a patient's local space or immediate surroundings can also be areas where reduced strain and unnecessary energy expenditure can be managed. Tools or tips like task prioritization, including the reduction or the elimination of non-essential tasks, can also be incredibly beneficial. And planning certain activities to align to higher energy levels throughout the day is vital. These can all be part of the care plan for energy conservation in concordance with the care team, which includes caregivers and family members, and then can have a major meaningful impact on the well-being of the individual. And finally, one area that is incredibly important and perhaps not talked about as often would be training carers, caregivers, and care partners. So physiotherapy professionals also play an important role here, stressing the importance of caregivers caring for themselves so that they can support their loved ones throughout this journey and stage of life. This can include instruction on safe patient handling techniques and transfers, positioning to prevent injuries, and exacerbation of issues like pressure sores or ulcers, and to ensure patient comfort. Teaching caregivers to care for themselves while being part of that care team is a part of the role that physiotherapy professionals bring. Strategies to help manage pain can also be taught. Oh, sorry, go back one there. Strategies to help help manage pain can also be taught, including, like I said, gentle range of motion or positioning so that the caregiver can provide that care, perhaps when a regulated professional or another member of the healthcare team may not be present. And again, really encouraging caregivers to recognize their own limits and energy management is a vital part of the overall care plan when someone is progressing through life-limiting illness. So these are only a few examples of the areas where physiotherapy professionals can provide compassionate care while maintaining health and well-being for the caregiving team. And finally, I'll just touch briefly on end-of-life comfort and care. So when we think about the final stages of life and how physiotherapy role can play a supportive role alongside other healthcare providers, physiotherapy professionals will tend to focus on non-invasive interventions like gentle movements and positioning to reduce discomfort and prevent complications from becoming worse, like pressure sores. Pain and discomfort management, breathlessness and respiratory support, preventing bed sores, circulation issues, and relaxation and stress reduction are all parts of end-of-life comfort care that a physiotherapy professional can support. And when we think specifically about the case study before us, we're really looking at cancer rehabilitation and care, and not to be confused with rehabilitation with the aim of recovery, but rehabilitation and moving through that journey. Not to say that an individual doesn't have goals at the end of life. Goals are still a very vital part of what makes us human, and those goals can still be ever present and even more meaningful at that stage of life. So when we think about cancer rehabilitation and exercise, that can play a vital role in supporting an individual's return to their activities. Regular activities become an incredibly important part of that self-identity, home life, and maintaining that balance through that stage of life and that progression. And physiotherapy professionals will be that partner in promoting the function, independence, and overall well-being right alongside our other partners in care like OT and SLP and audiology. And just to wrap it up, in terms of resources, I would really encourage those who are interested in learning more about how physiotherapy can provide that care, particular to cancer rehabilitation, to visit the Oncology Physiotherapy Division, a division of the Canadian Physiotherapy Association, where there are many resources, learning, and education opportunities that are geared towards health professionals and particularly for physiotherapy. And that through addressing these areas, you can learn more about how physiotherapists contribute to the well-being of individuals with life-limiting illnesses. I'd also like to leave you off with one final quote that came from a physiotherapy professional practicing in Ontario, noting that she found that people who were so appreciative of having a rehabilitation component because they are actually living their dying. They are dying, but they're living through it. And that they're in that moment and they still have goals and important things that they want to achieve. And I think that a physiotherapist's expertise can really, really help someone in that stage of life, and that the meaningful nature of the work should not be underestimated. Thank you.
Thank you, Lisa, and thank you everyone for allowing us to be here and talk about how speech-language pathology and audiology can contribute to the palliative care space, and also speak to how important communication access is in this space. Thank you so much. When you think about Joe's head and neck cancer diagnosis and subsequent symptoms, we can see that he's likely to experience the effects of many, if not all, of the systems listed here as he goes through his disease process. So he will have difficulties with voice, speech, language, possibly cognition, and very likely he will have dysphagia. So at the point of diagnosis of nasopharyngeal cancer, resonance of his voice is likely to be affected. Due to the pain and reduced ability to breathe through his nose, his ability to breathe while chewing may be reduced, lowering his tolerance for dry solids. During chemotherapy and radiation treatment, we want to do a baseline swallowing assessment, preferably an instrumental one, so we can look at the anatomical and physiological deficits and compare them over time. We would also do education on what Joe could expect during chemotherapy and radiation treatment and try to mitigate these effects. We could offer oral care recommendations to reduce the effects of xerostomia and mucositis, as well as give Joe swallowing and airway protection exercises that reduce the possibility of disuse atrophy and allow him to retain oral nourishment as long as possible. We would also monitor him throughout his treatment and afterward to support him as he goes through changes with speech, voice, cognitive, or swallowing mechanisms. In Joe's palliative phase, with brain and tongue mets, we know that Joe will also likely have increased difficulty with communication and swallowing. He may also experience cognitive changes near the end of his life, which may affect how he best receives and expresses information. Next slide, please. When health professionals understand and meet individual communication needs, it can improve medical and diagnostic accuracy. It can help patients understand their treatment options. It can ensure informed consent is truly informed. It can support individual and family decision-making. It can increase adherence to care recommendations, and it can enhance patients' autonomy and precipitation in their care. So I'd like to point out that communication strategies need to be responsive to the many fluctuations in the patient's abilities, which may be linked to, for example, medications or physical or mental health changes. For example, there might be optimal times in the day for important conversations. All patients should be able to receive communication in the way that they best understand, and they should be able to express themselves in the way that works best for them. SLP contributions, so we support communication strategies of the person, the family, and the team, alongside changing capabilities, enabling the person to participate in decision-making and maintain their social closeness to family and friends. Through giving the patient speaking strategies, so we might get them to repeat key phrases, spell out words, say keywords only to maximize, to minimize fatigue, maximize breath support for voice and energy and voice conservation, or with some patients, we might actually do voice or speech banking. Conversational strategy, so we might do communication partner training, training them to get confirmation that what was expressed is actually what was understood. Take into account the context and the attitude and humor of communication, which is not necessarily verbal. Nonverbal strategies such as positioning, gesture, vocal tone, facial expression, eye contact. And with some patients, we may use augmentative and alternative communication, which is AAC, which may be a communication chart, spelling board, text-to-speech program on someone's phone, low or high tech, etc. So the point is, if there is no communication support, communicative and cognition challenges may limit Joe's decision-making abilities, reduce his social and family connection, his connection with care team members, and reduce his dignity and autonomy at the end of life. I'm just going to move forward. Oh, there we go. Thank you. So dysphagia management, SLPs assess, diagnose, and manage eating, drinking, and swallowing difficulties, which can include sensory components, physical components, environmental, and behavioral aspects. We assess issues of swallowing and determine risks of aspiration, dehydration, and choking. We share the risk with the patient and their family to enable informed decision-making over beginning or withdrawing artificial nutrition and/or hydration, and or to support the team in making the least restrictive decision that aligns with the family and the patient's wishes. We liaise with the team to determine appropriate method of medication administration. We educate the team about oral care recommendations to minimize aspiration of oral bacteria and maximize comfort. And we educate and train family carers and the multidisciplinary team. Early on in the patient's journey, dysphagia care is often restorative and rehabilitative, and the focus will often be on minimizing aspiration, maximizing oral comfort, and maintaining and restoring swallowing function through compensatory maneuvers or swallowing exercises that are based on patient-specific anatomical and physiological deficits. As the disease progresses, goals will often change. At the end of life, the focus is not typically on minimizing aspiration or rehabilitating or maintaining function, but in respecting the patient and the family's wishes regarding quality of life and maximizing patient comfort. Informed decision-making is critical, and information must be presented in a way that the patient and family can understand. Next slide, please. Okay, thank you. SLPs educate individuals with terminal illnesses, their care partners, and other team members on cognitive, swallowing, and communication deficits, and on intervention approaches to optimize quality of life by addressing the needs and wishes of the individual and their care partners. Next slide, please. Thank you. So these quotes were gathered from family members who expressed gratitude regarding SLP involvement with communication and swallowing support at the end of life. In the quote on the left, the patient was able to use a low-tech AEC device to express information that was critically important to him. On the right, the quote came from a family member who, through informed decision-making with the SLP, patient, and the medical team, were able to enjoy a very meaningful mealtime together.
So thanks, Jennifer, and thanks to everyone else on the care team here helping Joe. I'm so pleased to be able to be here to represent the audiology perspective. And I'm going to start with a quote from one of my audiology colleagues, Barbara Weinstein. Hearing and communication are so critical at the end of life because at this stage, what people are left with is the need to communicate with family, physicians, and other caregivers. Doctors are very concerned with patient-centered care, but often have not been educated to appreciate the role that better hearing can play in that care. So just like Jen was talking about, the communication access and how that's a key piece, especially in a case like Joe's. And one of the things that stuck out in Joe's sort of expressing what he was experiencing was that he had some tinnitus. So for those of you unfamiliar with what tinnitus is, it's any perception of sound in the absence of an external sound. So that can be ringing, whooshing, hissing, clicking, humming, buzzing. And often it can range. It can be sort of not bothersome or extremely bothersome to the point that it can really impact a patient's mental health and well-being, can create tiredness, insomnia, headaches, and sometimes depression. One of the things from an audiology standpoint that really stuck out too is often when a patient is experiencing tinnitus, they also have hearing loss. And in Joe's case, because he is a cancer patient, it's likely that if he didn't have this tinnitus prior to receiving treatment for his cancer. It could be that one of his cancer medications is ototoxic, which can cause hearing loss, and sometimes a precursor or sort of first indication of hearing loss is the development of tinnitus. One of the key roles that audiology can play in a case like Joe's in particular is to be involved from the initial stages, to do a baseline hearing test, to monitor to see if there's any changes in hearing, to potentially prevent sort of hearing loss coming on, or even prevent this tinnitus type symptom. And then to someone's point, I noticed, oops, in the chat, someone brought up music therapy. So if Joe is having trouble hearing as a side effect from his tinnitus or otherwise, then being able to sort of treat this hearing loss would really help in terms of being able to administer musical therapy. So the role of the audiologist in this particular team would be to identify hearing and potentially balance issues, although Joe hasn't expressed any concerns about vertigo or balance, and to do a thorough tinnitus assessment. In doing so, the audiologist can provide hearing rehabilitation, potentially in the form of a hearing aid, maybe something called a pocket talker to help enable Joe to hear everything going on around him, or something as simple as, establishing communication strategies. So educating Joe, his family, his children, his caregivers, everyone involved in Joe's care, potential communication strategies to help ensure that Joe is fully informed and understanding of everything that's going on. Another role of the audiologist as part of this team is to increase Joe's comprehension and also the care team's comprehension to ensure that everyone on all sides understands what Joe's going through, what the treatment is that we're doing for Joe, and sort of enabling him to express himself and to keep his dignity, emotional well-being, and quality of life. So there is at Sunnybrook Hospital in Toronto, there is audiology involvement in the palliative care teams there. And so this is a quote from one of the palliative care doctors from Sunnybrook that I thought would be really nice to share with the team here. So the quote is, "Audiology services have honestly been life-changing at the end of life for some of our patients. Many patients have shared that because of audiology interventions, they were able to hear the voice of their loved one for the first time in years, or engage in music therapy near the end of their life. Some families shared that due to barriers to accessing appropriate hearing devices prior to coming to our unit, their loved one had not been able to engage in conversations about their own health, nor were they able to express wishes about end of life, and that it was incredibly dignifying for their loved one to be part of their own healthcare conversations now. The support and intervention offered by the audiology team have been imperative to quality of life and comfort for our patients in the palliative care unit."
Okay, so I think what we had planned to do, as everybody has already got access to the case, is jump to the Q&A to address any questions that anyone may have about
Perfect.
yeah.
Okay. Now, now I'm understanding. Okay, this is great. So I just want to thank everyone so much for this presentation. I have learned so much about what your roles, how important they are and what a vital part of the team are. And especially the earlier you can become a part of the team, the better, because those longitudinal relationships are so important. And I'm sure this has been helpful to a lot of people. I think this conversation has resonated with a lot of people in the chat. I'm seeing people from across Canada, a couple international folks as well. We've gotten a couple of questions in the Q&A and a couple in the comments that I'll bring to the surface. Carla asks whether most or all physiotherapists in particular are able to help in these kind of ways that you've described, or would they need additional palliative care specific training?
I can jump in to say that in my experience, while the techniques and skills associated with thinking about Joe's condition, edema or balance issues or strength loss or managing fatigue, you would achieve those concepts or competencies through your entry to practice education. However, the palliative care space can be a different space and can require a very different kind of energy and also a very different kind of communication with your team. So given that, I would suggest, assessing your own learning goals and your own learning comfort and seeking additional palliative training courses, any that offer an interdisciplinary approach, a patient-centered interdisciplinary approach would be ideal. There is one I'll pop in the response to that is offered geared towards physiotherapists. So Carla, happy to share that with you. It's available through our CPA learning modules. But I would say additional training across the continuum of your career would be incredibly beneficial to providing this kind of care. It's heavy work.
Thank you so much. I also wanted to bring up another question that came in earlier from John. He was saying, what is the best way to promote interdisciplinary communication in the community? Often it feels that the various disciplines are siloed in their individual roles. I can even speak to this in working in a family practice clinic where you've got interprofessionals, and still, even though you're in the same organization, same building, it can feel like silos. So how do we promote that interdisciplinary work together?
That is a really great question. I would like to offer that it's important that you are able to meet as a team and discuss things. So if you can have a weekly rounds or something similar, discuss patient cases, really learn from each other. I think that's very important. Create spaces for each other to share information.
Yeah, and I would just second that. I mentioned in the presentation that we started what's called whole community palliative rounds. And if you want to Google that under interior health, I believe they were the first to kind of establish that, but there's guidelines in that there that can help foster that process.
I just wanted to mention that these things do not necessarily need to take an excessive amount of time. From what I have understood and learned in my research is that people are able to do these things in moments and that people don't need much. But like, as we've heard from every discipline, that the community element has come up. So that sense of not being alone in the work that you're doing. And if we are being asked to take this on, we do need to be supported. And I think that this is something that we have to move towards and learn more about what the clinicians, the professionals' needs are, so that we can best support them.
Thank you so much. Really appreciate those thoughts. We had a question from someone asking whether we saw registered dietitians as having a role to support patients in their palliative care journey. In any of your work, can you speak to partnering with RDs in any way?
I've had the benefit of working in palliative care space, and it's definitely a different mode of working. Luckily, there was a dietitian available, and we worked very closely, especially when artificial nutrition had to be introduced or withdrawn. And often when people, even if they are on feeding tubes, often they can still take something PO, and we do work very, very closely together.
I'm also hoping that after listening to this presentation, that all of you will really, really understand that you do not need to be working in a palliative care space or set of services, the palliative care silo, that this is something that's integrated across the whole of healthcare and social systems. So it's an approach to care. It is not a set of services necessarily. So that means that every single member of the team would be involved, including people like volunteers and of course the the person, like the client themselves, is at the center of everything.
Absolutely. And I think I'm going to take one more question. There's so much in the Q&A, but also in the chat. And so I want everyone to know we will look through any questions that we didn't get through and see if we can provide any additional resources in the follow-up email that goes out. I just wanted to highlight Tiffany's question, really just highlighting the challenge when it comes to limited time. And Tiffany wonders, are you advocating for more hours in long-term care to support these services? They're desperately trying to have time to meet our residents' basic needs. Love the palliative care approach and became a champion, but we're having a challenging time implementing this. So any quick thoughts before we wrap up on what it's like?
I think that what we have to recognize is that caring itself, the fundamental nature of caring, is everybody's within everybody's innate sense of being and sense of self. So and that unless we are cared for, like as professionals, we shut that down. Like this is very challenging. So I think, again, like I mentioned before, that we need to learn more about this. How do we as clinicians feel supported in the work that we're doing? And I think it's easy for individuals or anybody to say, well, we don't have time. But what we're talking about here is integrating this into the work that we're already doing, but it does need to be supported.
Absolutely. Thank you so much. Given the amount of people that joined us today that registered and the level of engagement, this is clearly a need to gather together to talk about this. So I want to thank you so much. And I hope that we could maybe find some opportunities to do something similar again in the future and just keep building on this awareness and, just highlighting. I wrote down two words that really stuck to me. It's the dignity and autonomy. And I just want to thank you all and everyone in the audience for the work that you do to help people to maintain those important things. So thank you everyone for joining us. And if you haven't had a chance, please click on the link that's in the chat. That's going to lead you to the feedback survey. And we monitor that just for ongoing quality improvement. Thank you so much for joining, and we hope you have a wonderful weekend. It's Friday. Take care. Thank you, everyone. Thanks to our presenters.